Hello everyone. So today we shall deal with gingival inflammation. So this is a very common problem we encounter in our clinics. That is when a patient comes to our clinic with mild inflammation. So we should be able to differentiate the stage of gingivitis that the patient is being infected by. So let's resume with the topic and understand what are the main indications of gingival inflammation and how it can be staged into different stages, and the main features, that is microscopic features as well as the macroscopic features. So a clinically healthy gingiva consistently features a small infiltrate of inflammatory cells that involves both the junctional epithelium and the subadjacent connective tissue, according to Page and Schroeder in 1976. So the defensive factors of a clinically healthy gingiva are the intact barrier, which is provided by the junctional epithelium, the regular shedding of the epithelial cells into the oral cavity, and the positive flow of fluids, which is the gingival clavicular fluid, to the gingival crevice, which will wash away the unattached microorganisms and the noxious products. These are the defensive mechanisms. There is also presence of antibodies in the gingival clavicular fluid, which can act against the microbial products, and the phagocytic function of the neutrophils and the macrophages also contributes to the defensive mechanism. The detrimental effect of the complement on the microbiota is also a defensive mechanism. So the host microbial interplay or the balance must clearly change if gingivitis is to occur. So there should be a change in the balance, that is, from a healthy state, the balance has to tip into a disease state. So if there is sufficient plaque accumulation and retention, the microbial products will evoke a more substantiative inflammatory response. So it requires an etiology for gingivitis to occur. So in case of gingival inflammation, the body responds to an infection by developing an inflammatory response. The gingiva, as we know, is no exception, and inflammation of the gingiva is termed as gingivitis. It is described as progression from a state of health to a state of inflammation and tissue loss. So that is how we describe gingivitis. So the main causes of gingivitis or the risk factors involved in gingivitis include the most common cause is plaque, and the other risk factors could be the drugs that we take. It could be anti-seizure medications, calcium channel blockers, or drugs that suppress our immune systems, sometimes which can lead to gingival hyperplasia, making plaque removal really tough. So also other contributing factors include viral and fungal infections, which include acute herpetic gingival stomatitis or oral thrush. And other diseases and conditions involved in the manifestation as gingivitis are leukemia, oral lichen planus, and other autoimmune skin diseases, hormonal changes which occur during pregnancy, puberty, or due to intake of oral contraceptives also contribute to a great deal to gingivitis. Also, diet with poor deficiency in calcium or vitamin C and B can also contribute to gingivitis. Also, systemic diseases like diabetes mellitus, especially type 2 diabetes, also contributes to inflammatory gingival status, and this is because of the persistence of P. gingivalis with type 2 fimbriae, according to a study done by Makura in 2012. Also, the increase in HbA1c levels, which is an investigation to determine the glycemic level in the RBC in individuals with high levels of C-reactive protein, suggests an interaction between periodontitis and systemic inflammation. So, the mean value of visible plaque and visible inflammation showed significant increase also during orthodontic treatment. Therefore, prior to orthodontic treatment, it's also very essential for us to maintain a high level of periodontal health. and this should be maintained even during the treatment period, because there is a positive correlation found when a lower incisor retraction is done in during orthodontic treatment. It resulted in higher gingival recession. So, considering the relationship between orthodontic treatment and gingival health, it is essential that orthodontists and periodontists should cooperate during orthodontic treatment in order to keep the gingival inflammation under control. Now, what are the histopathologic features that we commonly encounter during gingivitis? The capillary beds open up in the gingival tissues. There will be increased exudation of gingival clavicular fluid and proteins. The tissue becomes edematous and swollen. The inflammatory cell accumulation occurs in the connective tissue, and the dominant cells are the plasma cells. And there is also collagen depletion. The pathologic changes during gingivitis are mainly associated with the presence of microorganisms, and they synthesize products that could toxins which could damage the epithelial cells as well as the connective tissue cells as well as the intercellular constituents. So when the intercellular constituents are broken, it causes the seepage of anti-inflammatory or rather defensive cells from the connective tissue into the gingival crevice. So this results in widening of spaces between the junctional epithelial cells, and it permits injurious agents to gain access into the connective tissue. That is, agents not only come out of the connective tissue, also it permits the entry of injurious or noxious agents into the connective tissue. So these microbial products will activate the monocytes or macrophages to produce vasoactive substances like prostaglandin E2, interferons, tumor necrosis factors, and interleukin-1. So the different stages that we encounter during gingivitis can be classified according to Page and Schroeder, who define the lesions under various categories, that is stage 1, stage 2, and stage 3. This chart was framed by them in 1976. So here the stages in gingivitis was stage 1, which could be called the initial lesion. It occurs within 2 to 4 days. So the first sign that we see in the blood vessel is vascular dilation or vasculitis, which occurs, that is the inflammation of the blood vessels, and the changes that occur in the junctional and the sulcular epithelium is that there will be an infiltration of polymorphonuclear neutrophils, and the predominant immune cells here is the polymorphonuclear neutrophils, and the main sign of this is the perivascular loss of collagen, and the clinical finding is there will be an increase in the gingival clavicular fluid flow. Then the stage 2, which is also known as early lesion, which occurs within 4 to 7 days of plaque accumulation or any other etiological factor, is there will be vascular proliferation, and the changes in the junctional and sulcular epithelium is same as stage 1, and there will be formation of retapex and atrophic areas in the junctional epithelium, and predominant cells during the early lesion, that is stage 2, is lymphocytes, and there will be increased loss of collagen around the filtrate, and also there will be erythema and bleeding on protein. Then stage 3 is also known as established lesion. So the time period which where it occurs is after around 14 to 21 days, that is around after 2 to 3 weeks. So here the blood vessels appear similar to that of stage 2, but there will also be blood stasis, that is the circulation of the blood vessel will be in, there will be an stasis, or rather you could say stoppage in the normal blood flow. So here the changes in the junctional and sulcular epithelium same as stage 2, but it's more advanced. That is, there will be more atrophic areas and more alterations in the tissues, and the predominant immune cells will be the plasma cells. So the initial stage we find the neutrophils, the second stage it is the lymphocytes, and the third stage it is the plasma. Here there will be continued loss of collagen, and there will be a marked change in the color, size, and texture of the gingiva. So this is the main change seen in the establishment. We can go into the details later. So the initial and early lesions are characterized pathologically of a clinically healthy gingiva and early stages of gingivitis. So you can call the initial lesion as a having a better prognosis because it is the early stage of gingivitis, whereas the established lesion is usually a feature of chronic gingivitis, and an advanced lesion is that lesion which could progress to periodontitis. So it can be associated with the attachment loss and bone loss. So going into the details of the different stages of gingivitis. So the initial lesion can also be called as subclinical gingivitis. So here there will be dilated capillaries and increased blood flow. So the presence of microbes will activate the resident leukocytes, and the subsequent stimulation of the endothelial cells. There will be increase in the migration of leukocytes from within the gingival sulcus, which in turn will cause an increase in the flow of gingival fluid into the sulcus. So the polymorphonuclear neutrophils will migrate into the site where the microbes attack the epithelia. So this is facilitated by intercellular adhesion molecules, that's ICAM1 molecules, and also endothelial leukocyte adhesion molecules, that is PLAM1, and other adhesions in the dentogingival vasculature. So this binding of polymorphonuclear neutrophils cells to the venules will help the cells to leave the blood vessels and enter the site where the bacterial invasion is occurred. So also this migration is assisted by other adhesion molecules and also presence of microbial chemotactic factors. So microscopically, there will be changes in the blood vessel morphological features with widening of small capillaries and venules and the neutrophils which adhere to the vessel walls, and the process is known as margination, which occurs within 2 to 7 days of plaque accumulation, and the polymorphonuclear neutrophils will leave the capillaries by migrating through the walls, and this process of leaving the capillaries by migrating through the walls of the capillaries is known as diapedesis or emigration. So there will be increased quantities in the connective tissue, the junctional epithelium, as well as gingival sulcus, and the exudation of fluid from the gingival sulcus and extravascular proteins are also present. So leukocytes are the predominant cells in this area, and they come out of the cells, that is through the walls, that is by the process of diapedesis or emigration. So the next stage is stage 2 gingivitis or the early lesion. So within 1 week after the beginning of plaque accumulation, the clinical signs of erythema and bleeding on probing start. So between 6 to 12 days, the maximal gingival fluid flow occurs, and the number of leukocytes also increases. Here, the collagen destruction starts to increase up to 70%, and the most affected fibers are the circular fibers and the dentogingival fibers. So this is a picture depicting the marginal gingivitis and how the gingivitis can cause irregular gingival contours. So the normal scalloped appearance is lost, and the nitrate appearance of the gingiva is lost, and it results in an edematous appearance involving the marginal gingiva as well as the interdental gingiva in this picture. So the neutrophils are found in the epithelium emerging in the pocket area. They engulf the bacteria, and by the process of phagocytosis, they kill the microorganisms through the release of lysosomes. So collagen degradation is related mainly to the production of matrix metalloproteinase 2 and 9 production and activation, which occurs within the first 7 days of inflammation. So microscopically, when you examine the site, you find that leukocyte infiltration into the connective tissue occurs beneath the junctional epithelium. So the lymphocytes, which constitute 75%, majority of T lymphocytes, then migrating neutrophils as well as macrophages, plasma cells, and mast cells are present at this site. And the junctional epithelium and gingival sulcus becomes densely infiltrated with these neutrophils. So that with that we come to an end of what stage 2 gingivitis is. Now, when the gingivitis has progressed further, then it is referred to as stage 3 gingivitis, and this is known as the established lesion. So it is characterized by a predominance of plasma cells and B lymphocytes, and there will be localized gingival anoxemia. So, and the gingiva becomes moderate to severely inflamed depending on the rate of inflammation at the site, and collagenolytic activity is increased in the inflamed gingival tissue by the enzyme release of enzyme collagenase, and there will be elevated levels of various enzymes like acid and alkaline phosphatase, beta glucuronidase, beta glucosidase, beta galactosidase, esterases, aminopeptidases, and cytochrome oxidase. So all these enzymes are elevated in the stage 3 gingivitis. And histologically, it also shows an intense chronic inflammatory reaction. So the preponderant inflammatory cell type which invades deep into the connective tissue is the plasma cell, which occurs around the blood vessels and between the bundles of the collagen fibers. So the junctional epithelium in this stage will reveal widened intercellular spaces which are filled with granular cellular debris, including lysosomes. So there will be lysosomes as well, which contain acid hydrolysis, which are mainly responsible for the tissue degeneration and tissue destruction. So the main cells that occur, the inflammatory cell that occurs here is the plasma. So the junctional epithelium also develops retipex or ridges which protrude into the connective tissue, and here the basal lamina becomes destroyed in some of the areas. So the connective tissue and collagen fibers will be destroyed around the infiltrate, where the plasma cells have infiltrated, and besides plasma cells, there are also neutrophils, lymphocytes, monocytes, and mast cells at this site. So the established lesion, that is a stage 3 gingivitis, can be of two types. It can either remain stable and not progress for even months or years, whereas the other type, it seems to become more active and it converts progressively to destructive lesion. So the lesion can either remain stable or it can progress to a destructive lesion. And when it progresses to a destructive lesion, it leads to the stage 4 gingivitis for the advanced lesion. So this advanced lesion is the phase of periodontal breakdown. That is when the gingivitis or the inflammation or the inflammatory lesion extends into the alveolar bone. So there will be loss of connective tissue attachment as well as alveolar bone. And there will be extensive damage caused to the collagen fiber. The inflammatory cell infiltrate will extend into the connective tissue of the true attachment activity. And here the plasma cells are the dominant type in the stage 4 gingivitis as well. So here the term gingivitis will now be replaced by periodontitis as the lesion will progress further, and it will mainly affect only those individuals who are susceptible. So it is seen that when patients had a gingival index of 2 and consistent bleeding, they were more prone to the attachment loss, and also persistent gingivitis always represented a risk factor for periodontal attachment loss and tooth loss. So even when a person has persistent gingivitis, it is definitely a risk factor as it can progress to periodontitis at any time. So this is a pictorial representation of the different stages of gingivitis. Here, the first picture shows a pristine gingiva. Pristine gingiva is an assumption, or rather we could say that such a gingiva rarely exists. It is a gingiva where there is no microbial infiltration or inflammation at all. That is perfectly healthy gingiva. And the second picture shows the normal healthy gingiva. That is when there is a minor collection of plaque and slightly infiltrated connective tissue, which is the normal gingiva we encounter during our patient examination. This is the type of gingiva we normally come across when we examine a patient. Here you find there are small amounts of inflammatory cells involved. That is the monocytes, macrophages, lymphocytes, and neutrophils. Now, the third picture depicts the stage of early gingivitis when there is an increased infiltrate and the presence of neutrophils, lymphocytes, monocytes, and macrophages. Here, the vessels become dilated and the vascular proliferation occurs with increased collagen loss. Now, the fourth picture depicts the picture of established gingivitis when there is a marked increase in the inflammatory infiltration, the proliferation of the junction epithelium. Here, there is an increase of plasma cells, and which constitute to 10 to 30%, and finally and eventually progresses to periodontitis, where there will be an apical migration of junctional epithelium, increase in the plasma cells, and also progressive alveolar bone loss. So these pictures show the different stages of gingivitis. The clinical signs that we come across in gingivitis are redness and sponginess of the gingival tissue. There will be bleeding on provocation and changes in the contour of the, that is, there will be variations in the contour of the gingiva, and also definitely there will be presence of a etiologic factor like the calculus or plaque, and also there will be radiographically no evidence of crustal bone loss. Now, there are, according to the course and duration, there are different, the gingivitis can be of different types. That is, it may occur on sudden onset or it can occur, it can occur within a short duration. Then the different types of gingivitis that we come across are recurrent gingivitis. That is gingivitis which recurs or reappears after the etiology has been removed. Then chronic gingivitis, which is slow in onset and of long duration. And gingivitis could also be localized when it's confined to a single area, a single tooth or a group of teeth, or it can be generalized when it involves the entire mouth. Then depending on the location or the site involved, the gingivitis can again be differentiated as marginal gingivitis, which involves the gingival margin alone, or papillary gingivitis when only the interdental papilla is involved, and diffuse, which affects the gingival margin, the attached gingiva, as well as the interdental papilla. Now, this can again be differentiated as either localized or generalized. That is, the marginal, diffuse, and papillary gingivitis can again be differentiated as localized as well as generalized, depending on the amount of area involved. So this is the picture depicting the localized gingivitis. The picture on the right shows the localized gingivitis, and the picture on the left indicates generalized gingivitis, and the entire mouth is involved. So we can see the local factors involved and presence of plaque and calculus. And whereas in the second picture, we see that only the lateral incisor area is involved. Also, this is an example of generalized gingivitis, and another picture depicting the papillary gingivitis. So here, only the second picture shows only the papillary area is involved or inflamed, and the first picture there is a diffuse involved. That is the entire area, or we can see the marginal, the papillary, as well as the attached gingiva involved. So with that, we come to an end of this session. So we can conclude by saying that the inflammatory and immune reactions to microbial plaque is the predominant feature of gingivitis and periodontitis. So it is the inflammatory reaction of the gingiva to the plaque or calculus which is present in the mouth. So for patients in whom this acute inflammatory changes predominate, clinicians can expect a more dramatic response to the initial therapy. Whereas in patients with an established or advanced lesion, then such a significant tissue response will not occur. So it is always advisable to treat the lesion during its initial stages rather than wait for it to progress to an advanced stage. So patient education as well as patient management is very important. And the more inflamed the gingival unit appears clinically, the better the chances of therapeutic measures resulting in a return to the normal gingival. So what we understand from this is that even though a gingival unit can appear inflamed, this sign of inflammation itself, or rather we can say the signs of erythema or redness or other signs of inflammation is actually a positive indicative factor indicating that when we treat the area, it will definitely progress to a dramatic response. That is, it will definitely progress to a positive response. And as the vascularity in the area is very good, and also it can there are better or rather higher chances for such an inflamed area to return to a normal gingiva. So let's all be good clinicians and diagnose the presence of these gingival inflammatory signs in the initial visit of the patient, and let us also always strive to educate the patient. That is it is not only essential for us to educate the patient to keep his or her oral hygiene in the best possible way. It's also essential for us to do whatever a clinician can do, that is to clean the area either mechanically or through the use of ultrasonic devices, and help the patient to maintain his or her gingival health. Thank you.